Okay. I want to apologize first and foremost for my voice. I'm going to try to fight through this as best as I can and as understandable. This was obviously not planned, but yeah, I hope it's gonna last until the end of the webinar. So yeah, welcome all of you for and thank you for joining today's webinar. My name is Dr. Sofia Wenzler. I'm a licensed clinical psychologist and the clinical lead here at TrickStop. TrickStop is the therapist-assisted online therapy program that can help you manage hair pulling. And today we're going to talk about OCD and hair pulling, the similarities, the differences, and how to treat them. And I want to encourage you to stick around until the end. I'm going to talk for about 40 minutes, hopefully. And then we're going to have a Q&A session where you can ask all the questions that might come up during the presentation or after. And I want to ask you to write those questions down in the Q&A section. Please don't raise your hand, just write the question down. And in the end, I'm going to get to as many of those as I can. Okay, so we're going to start by me explaining to you a little bit about what OCD actually is. I'm going to invest more time in that than talking about what hair pulling disorder is, because I think most of you are very familiar with that. But then we're going to look at how the two are similar in terms of how they manifest, but also in terms of how they are based on these imbalances in brain functioning. So they have shared underlying neural correlates that we're going to look at. And then we're going to talk about how to treat OCD in comparison to hair pulling. And I'm going to try to make this a little bit more practical and less theoretical by using a case example. Then we're going to conclude and I'm going to answer some questions, hopefully. Okay, so OCD can take many different shapes and forms, as you're going to see. But in a nutshell, and at the base of it, it is always a cycle that has most of the time the same elements. To give you an example here, I'm going to take one of the most known forms of OCD, which would be contamination OCD and the stereotypical doorknob. So in that example, the trigger for the OCD in that case would be seeing a doorknob, okay, which is something we all know. And then even the intrusive thought, an intrusive thought means that it's an unwanted, unpleasant thought that comes up without us actually wanting it to come up and without any control over it. This intrusive thought might be, oh, this doorknob might be contaminated. Maybe there are germs on it. Who touched it before me? And that is also something that a lot of us actually have experienced probably at some point in their lives or many times. The point where the actual pathological part of this OCD cycle starts is with the interpretation. So if I see the doorknob and then think there's germs on it, and then interpret this as very dangerous and think about how the germs are crawling up my arm, or have an inner picture of the germs, or I think about which illness I might contract from this doorknob. This is where the problem starts, because then I get stress. I feel distress or anxiety. And if the anxiety is intense enough, then I might feel that I have to do something to relieve the anxiety. And in OCD, that can be either a compulsion without T. There's a little typo, I'm sorry. A compulsion, or we also call it rituals, would be some kind of action that makes me feel better. For example, washing my hands or using this antibacterial gel. And usually those rituals or compulsions are performed more than once. But it can also be avoidance behavior. For example, avoiding doorknobs or touching the doorknob only when you have a sleeve that is long enough so you can pull it over your hands, or wearing gloves. And that compulsion or avoidance behavior is problematic, because as long as we use that, we can never have the experience of, okay, I touched the doorknob, I touched many doorknobs and nothing happened. So maybe the doorknob is not as dangerous as I thought. So that would be like a classic example of OCD. But we're going to dive deeper into this whole topic. Um, One interesting thing when you think about OCD and hair pulling is that OCD is much more talked about in public. There is more if you go on ChatGPT and ask about, for example, what famous people do we know with OCD, you will get a much longer list of people who talk openly about their OCD than about hair pulling disorder, which is interesting because they are they are about as common, OCD and hair pulling disorder. So it's not that we have much more people suffering from OCD than hair pulling disorder. And we know for the hair pulling disorder or skin picking and other body focused repetitive behaviors, um, that the fact that we don't talk about them enough leads to stigma and misconceptions, and people feeling very alone and isolated with their problems. So maybe with OCD, that is a little better. And maybe hopefully we're working on the stigma with OCD, and also obviously that's what we want for hair pulling disorder. But with OCD, although we talk about it more, there's still a lot of misconceptions. So not everything you will read about OCD or hear about it is necessarily true. Some very common misconceptions is, for example, this idea that OCD is just or mostly about being neat or clean, or having some need to the need to for things to be in order or perfect or things like that. But that is false in two ways. First of all, there's many different kinds of OCD that we're going to talk about, and OCD that involves the need, for example, for things to be clean is just one of them. Contamination OCD, which we just talked about when we talked about the cycle. But there is more, and we're going to get into that. And secondly, even if it is contamination OCD and we are talking about things need to be neat and clean, then OCD is much more than that. It's, it's a psychological disorder that ha has criteria for diagnosis, and one of them is that it has to lead to significant impairment or distress. We're talking about compulsions / rituals that take up 1 hour or more of your day. So it's not someone who is like extra tidy or just likes his house to be clean, likes their house to be clean. It's much more than that. Taking a sip. Okay. The second misconception, everyone has a little OCD. That is also not true for several reasons. Actually, there is a little bit of truth in there. Because, as I mentioned before, with the doorknob, intrusive thoughts are actually not foreign to a lot of people. I think, based on studies, there's 80 to 90%. I think, in my opinion, it's everyone knows some sort of intrusive thought. Maybe they don't know what an intrusive thought is, but most people have those because it is basically just white noise of the brain. The brain is always active. We always have thoughts in our heads, and sometimes weird ones come up. Um, and some of them we don't really want to think, but we have them. Can be that you're standing next to a balcony and all of a sudden think, oh, what if I jumped? Or if you, I don't know, you talk to someone and all of a sudden you have this weird thought of like, what if I would just curse them now? Um, Although you really don't want to. And most people just think, oh, that's a weird thought. And then they move on. So most people know intrusive thoughts, but the struggle of actually being scared by those thoughts and engaging in multiple, um, um, oftentimes debilitating compulsions and rituals is something that just about 2% of the population know. So comparing quirks to clinical OCD is invalidating the actual struggle of people who suffer from it. Um, and then there's also this weird, like, not, but this like idea that OCD has something to do with personality, or that it's actually a personality trait. That is not true. Our personality means something. Usually, personality traits are something that we are in line with, that we feel are part of ourselves. And compulsions are not. Compulsions are intrusive thoughts, are unwanted, and people who suffer from them feel like they're not part of themselves and they don't want them, so they don't feel like, yeah, I think those are the best words that I can find, that those are part of themselves or part of their personality. It's not the way that they want to be or live. We do know, however, another disorder that sounds very different. um, it sounds very similar, but is actually also different. Obsessive compulsive personality disorder, OCPD. So that's a different disorder. Almost sounds like it's people who have OCD that turn into a personality, but that's not true. It's just people where a need for order or for certain rules or for perfectionism is actually part of their personality. And those people usually think that those rules, or having everything neat and clean, they don't think that this is exaggerated. They think this makes perfect sense. It's part of themselves, it's part of their personality. We call this ego syntonic. It's synchronized with our values or what we feel is right. But we still define it as a disorder because it can cause significant impairment to, for example, relationships. It's sometimes not easy to live with a person like that, or at work, because sometimes it's hard to get, tasks done if you have really high and perfectionist standards for those tasks. Um, so yeah, it's OCD is not a personality trait. I want to give this a little bit more color by talking about a case example of a client that I actually treated in my private practice in the past. I'm not going to give you any real details about their lives or them as a person. This is also not their real name, but we're going to call him, for now, we're going to call him Steve. Um, he was 20 years old when we started therapy, and actually, um, after we scheduled the first session, when the session was supposed to take place, he didn't show up. We had a phone call where he told me, like, I just had several panic attacks. I feel like I'm completely losing my mind. I took some Xanax, and now I'm just too sedated to leave the house. So he was in really bad shape, and he didn't know what was going on at this moment. Obviously, me neither, because I hadn't met him yet. But luckily, for the second appointment that we scheduled, he was able to show up. And then we realized that he had OCD, and his OCD was around the fear of hurting himself or a person that is dear to him. In this case, this involved mostly his girlfriend that he was living with. So he had intrusive thoughts and pictures that came up without him wanting, in his head, of, for example, stabbing her, or hurting her, or hurting himself. And he had also, this was a very interesting case where the OCD kind of really, this kind of OCD, we later realized that he had other kinds of OCD in the past, but this really intense episode of OCD had broken out just several weeks before, and within weeks had taken over his whole life. And he had several compulsions, or again, rituals, um, where he had exchanged the knives in his apartment with plastic knives. He was sitting on his hands. He distanced himself from his girlfriend. He would go to bed, I think, later than her, because in that way it reduced the chance in his head for him accidentally hurting her when they were sleeping next to each other. And he also had a lot of avoidance behavior. So he wasn't driving anymore. He was barely leaving his house. Um, didn't meet friends very much, because his fear was that, like, the intrusive thoughts were in his head so much that he thought he wasn't even able to have a decent conversation anymore. So OCD, you see how this is not quirky. or is that just someone being neat or clean. This is debilitating. This is really, really difficult sometimes. Um, and so Steve is with Steve, you already see, there's different kinds. We found out that he had other kinds of OCD as well. So it is also one person can have different obsessions, several obsessions at the same time. But there's different groups. There's actually a lot of different groups of OCD. I'm just giving you some examples here that are also quite common. So you do have the contamination OCD, but you also have all kinds of OCDs that are related to morals or being a good person. For example, if you're religious, sometimes there's religious obsessions where people suffer from unwanted blasphemous thoughts, so thoughts that show some kind of lack of respect for God or for religion. For example, the thought that I might curse God or that I might commit some kind of sin. Then there's intrusive thoughts around the topic of sexuality. Um, so those are usually unwanted, forbidden, scary, and morally unacceptable thoughts, images, or ideas. Sometimes it's also about sexual orientation, intrusive thoughts about having another sexual, um, is it called identification? No, sexual orientation. Yeah, then you actually have, and also violent or aggressive thoughts, just like Steve had. And then there's relationship OCD, which is actually a new kind of like recently that we talk about that, where it's intrusive thoughts about or worrying that the relationship we chose is not the right for us or that our partner is not right for us. Um, then there's responsibility for harm OCD, which is also quite known. It's when this thing where we have to check several times whether the stove is turned off or the door is locked and things like that because we're afraid we might cause some kind of harm if we are not 100% sure that we lock the door and check the stove. Um, just right OCD is a little different. It's actually the only kind of obsession where we don't have intrusive thoughts. It's usually just things have to be a certain way or I have to do things for a certain amount of time. Otherwise, it feels not right. And this not right is really, really uncomfortable. And that can be that things have to be in a certain order, or it can be about symmetry. It can be about if I do something with my right hand, I have to do my left hand. I have to tap things for a certain amount of time. Um, those kind of things. And then there's hoarding OCD, where I feel like I have intrusive thoughts about throwing things away. So throwing things away can be scary because I have intrusive thoughts of me being a bad person. For example, if it's like a gift, something that has some kind of emotional value for me, it might be that I don't love the person who gave this to me anymore, or even more rational thoughts that if I throw something away, something bad will happen, like a plane will crash or something like that. And there's much more. OCD can basically sit on anything, on any topic imaginable. What I tell my patients usually is that OCD is just like a bully who identifies your weaknesses and what's important and dear to you, and that's where it will sit. For Steve, for example, it was important to be a good person, a peaceful person who wouldn't hurt other people, specifically not the ones that he loved. And that's why he had OCD around those topics. People who have a high need for safety, for example, might tend to contamination OCD because then the fear is that I'm not safe, that I actually am going to contract an illness or something like that. So it's a really mean condition, but once you realize that the OCD is a bully, that it can also have, help you in terms of therapy. We're going to talk about that. Um, so how are OCD and hair pulling similar? Actually, if you look at the DSM or the ICD, two kind of manuals that help us diagnose psychological and physical disorders, then you will see that they are grouped in the same group. And this group is called obsessive compulsive and related disorders, OCRDs. And here we have BFRBs. The most talked about ones are hair pulling disorder and skin picking disorder. Also hoarding disorder, which is a little bit different from hoarding OCD, and body dysmorphic disorder. And what kind of makes those disorders fit in the same group is the fact that they all include compulsive behavior. And a compulsion, the best definition that I can give for a compulsion is it's something that is hard to control, repetitive, unwanted, and leads to some kind of relief. So it's an action that I do again and again, although I don't want, I can't stop because it feels good for some kind of reason. It gives me pause from some kind of distress, or it gives me some kind of pleasure or relief. But in the long run, um, it causes problems, and that's why it's unwanted. And you can look from that perspective as at hair pulling disorder as well as OCD. Another thing that they have in common is the cyclic nature of OCD and hair pulling disorder. So with hair pulling, as you know, there's a trigger that can be all kinds of things. And then you feel an urge. The urge can be felt like really wanting to do the pulling, but also it can be felt physically. Then you do the pulling, you feel some kind of relief, but afterwards you feel bad because you didn't really want to pull out hair, and makes you feel regret or shame or other negative feelings. And with OCD, as I just explained before, it's the same. The triggers are different though. So for OCD, it's mostly really those intrusive thoughts, except for the just right OCD. So it's usually some thought that is related to some kind of fear that then causes distress and then causes this whole cycle. Um, with hair pulling, it can be more things. It can be boredom. It can be a distressful thought for sure, but it can also be negative emotions. It can be some nervous energy that is being built up during sedentary activities like sitting in front of a TV. Sometimes it's just my hand being close to my head, right? So the triggers are there's much more variety in the triggers for hair pulling. Halfway through the presentation and my voice is still here. Okay, looking good. Um, and then there's actually cases where people have both of them, unfortunately. Um, and the co-occurrence or comorbidity of hair pulling disorder and OCD lies between 7 to 28%. So if I go to the higher end of the spectrum, you could say that almost every fourth person who suffers from hair pulling disorder also has OCD. And that might have something to do with the fact that they share some they share some imbalances in brain functioning, both of those disorders. And those, I want to just disclaimer, okay, this is not the whole neuro those are not all neural correlates of those disorders, right? It's just one correlates, one imbalance in the brain functioning that is involved in both disorders, but it's more complex for both of them. But it's actually interesting to think about that. So I'm going to explain. We're talking about some a circuit, okay, that involves different brain regions. I don't know how to pronounce this in English, so this is the German coming out here. We're talking about the cortico-striatothalamocortical circuit. I'm going to call it the CSTC circuit. So it's a pathway from the cortex, which is the outer layer of our brain, deeper inside to the brain to the striatum, to the thalamus, and back to the cortex, CSTC circuit. And this circuit helps the brain decide whether to act on a thought or impulse or to stop and ignore um, this impulse. So it's like a balance between activation and inhibition, between um, go and stop. Um, and it works like this. So the cortex, again, is the outer layer of the brain. It's responsible for higher level functions like critical thinking, planning, or decision making. And this is the part of the brain that kind of connects to your senses and um, is given information on what's going on around you and then formulates thoughts based on that information. For example, if your senses, your eyes, see a hair whose texture seems out of place in a certain place on your body, then your cortex might get that information and generate a thought like, I need to do something with this hair. This hair bothers me. And then this information is then passed on to the striatum. And I'm really simplifying here. I'm also not a brain expert, but I do think it's very interesting. I'm just trying to give you the general idea. So the striatum receives the signal from the cortex, and then the striatum is the part of our brain that will decide whether to act or not. So, for example, if the cortex says that the hair bothers us, then the striatum will evaluate whether it is a good idea to pull that hair out or to cut it off or to do something with it. And it makes the decision and then sends this decision to the thalamus, which is called the brain's relay station. And the thalamus filters information and takes information and then signals it right back to the cortex. In this hair pulling example, for example, the thalamus will help to inform the cortex about the progress that we made while we were pulling the hair. And so in this cycle that is usually, a really interesting part of our brain when we're talking about hair pulling or OCD. There's reduced activity and connectivity between all of those areas, and that's what leads to problems and to the compulsive behavior. We're going to look at it also from the perspective of OCD. So again, we have this cortex striatum thalamus cortex circuit. And when we take an OCD example, for example, let's say the contamination OCD, then the cortex, for example, would be the one that kind of sees the doorknob, gets this information from visual information, and then formulates the thought. I just touched the doorknob of a public bathroom. There might have been dangerous germs on it, and that creates anxiety. Apart from the anxiety, that thought is then sent over to the striatum. But you can already see that in people with OCD, those assumptions and thoughts that the cortex generates might be a little bit exaggerated in terms of the danger that we're actually facing um, as compared to someone who doesn't suffer from OCD. So it's already this evaluation or belief that a doorknob in a public bathroom might lead to great danger that starts the OCD symptoms. But then when we go one step further to the striatum, then here we see that in that case, for example, the striatum would assume, okay, the best thing to do is probably to wash our hands. But in OCD specifically, also in hair pulling disorder, we have problems with action inhibition here. So the idea of like, okay, maybe we're just like not washing our hands and just see what happens if we're going to die or not, that is not happening with OCD. Um, and then this information is passed over to the thalamus. And what happens in OCD with the thalamus and in this connection between the striatum and the thalamus and the cortex is that the thalamus fails to put a check sign on an action. So many times, like we wash our hands, but then the thalamus is not able to say, okay, now we washed it enough. We washed the hands are not clean, we can go on. So we wash our hands again and again, or for really extended periods. Yeah, and that's how connectivity works differently for OCD or hair pulling in this CSTC circuit. And when we're talking about connectivity or information being passed on from one point to the other in the brain, then we're talking about neurotransmitters, because neurotransmitters are the special chemicals in the brain or in the nervous system that help transmit signals between nerve cells. So when we talk about some kind of problem with connectivity, then it's usually that we have too much or too little of a certain neurotransmitter. And in this CSTC circuit, the most important neurotransmitters would be dopamine, glutamate, and GABA. Glutamate and GABA are kind of two transmitters that balance each other out. One is more involved in action inhibition, and one is more involved in action activation. And then we have dopamine, which maybe you heard before. It's actually involved in a lot of, or we think it's involved in a lot of psychological problems. Because to be perfectly honest, to my best knowledge, again, I'm not a neurologist, but there's no way to yet to really measure neurotransmitters in the brain, but we can assume through other ways about how much this neurotransmitter is present in the brain or not present, but it's really not exact, and there's a lot we don't know. I just want to say this as a disclaimer. But anyway, so dopamine is really involved in a lot of psychological disorders that are related to compulsive behavior. The interesting thing is that it can be reduced levels in dopamine and it can be elevated levels in dopamine, and both of those would lead to um, lead to compulsive behavior. So the brain basically can be overstimulated or understimulated. In ADHD and Parkinson's disease, for example, it is a reduction of dopamine. That's why stimulants such as Ritalin work in increasing dopamine levels. And for OCD, skin picking disorder, and hair pulling disorder, we talk about elevated levels of dopamine that lead to the compulsive behavior. All right, short break. Yeah, so that's very interesting what's going on in the brain. Let's talk about what to do when you have OCD or hair pulling disorder. So actually, the similar aspect is that the gold standard treatment, or one of the most effective treatments that we know for both of them, is cognitive behavioral therapy, in short, CBT. Um, but there are two different versions of CBT that have been specifically designed for um, hair pulling disorder and OCD. For hair pulling disorder, it's habit reversal training, and for OCD, it's exposure with response prevention. But in both cases, it's basically it's the CBT. It's trying to change the way we think about things and our awareness about things, and then trying to change our behavior in order to reduce the stress and symptoms. And then acceptance and commitment therapy, which is basically like a third wave CBT version that includes also aspects that we know from Buddhism, such as acceptance and mindfulness, is also been proven to be effective for both of them. And then in both cases, sometimes medication can help as well. If we look at the medication, then for OCD, the most prescribed and most effective medication that we know so far are selective serotonin reuptake inhibitors, in short, SSRIs, the same medication that we also give for depression and anxiety and other things, just in a really high dosage. Um, and that also shows you that it's not, for example, we talked about dopamine before, but there's different neurotransmitters involved in OCD. The CSTC circuit is just one aspect of the brain functioning that's involved. And for hair pulling, we actually have much less research, and I'm not a psychiatrist here, so I'm not recommending any medication, but based on a recent study that came out, we know that NAC is very promising when it comes to hair pulling disorder. That is actually a medication that works on glutamate, another neurotransmitter that's really involved in the CSTC circuit. And then aripiprazole, a modern an atypical antipsychotic, and MAOIs, which are also antidepressants, but not the same as selective serotonin we take in inhibitors. And in both cases, medication is not always recommended, but in some cases. Like in both disorders, it is only recommended in some cases. Okay, so when we talk about cognitive behavioral therapy for hair pulling, talk about habit reversal training. Not going to go into much detail here because I think most of you have heard about that before, and we have designated webinars on that topic that you can find in our YouTube the channels. And the main steps in habit reversal training would be self-monitoring to create awareness. So we try to create awareness for the pulling, because sometimes we do it without even noticing. And we also try to create awareness um, about our triggers, like when did the pulling happen? What are the things that led to the pulling, so we understand it better, and so we can then reduce triggers through stimulus control techniques and try to find different ways to cope with the urges, and we call that competing response. So you have the behavioral part and you have the cognitive part. For OCD, we're still working with the cycle. You see how like CBT is this very structured approach, and very focused and structured. And you will see how the CBT, the in this case exposure with response prevention, only starts. It doesn't start. It doesn't try to change triggers. It doesn't try to change the intrusive thoughts because you can't. This is actually something that a lot of people with OCD don't like hearing. They don't want to have those thoughts anymore. They want to learn to control them. But that's exactly part of the problem. You have to accept that intrusive thoughts are part of life. We're not changing those. We all have them. But we're starting with this problematic interpretation. The first thing we do in CBT is challenge exaggerated beliefs and distorted interpretations of those thoughts. For example, that doorknobs are dangerous. And then in a second step, oops, how did that happen? Wait, no, right here. In a second step, we're basically trying to create the ability to cope with the stress, to not immediately engage in a compulsion or ritual once we feel the distress, and then to reduce compulsions and avoidance behavior. And I'm going to explain this to you by going into the example with Steve again. Just hope the slides are going to align with me here. I think so. So with Steve, again, I'm reminding you this is a person who had violent, intrusive thoughts about hurting himself or his partner. The first thing was psychoeducation, was teaching him about OCD and trying to help him learn what that actually is. So we started from, you are not losing it, okay? You're not going crazy. This is a disorder that is known. You're not the only one who has it, and it's treatable. And the thoughts that you're having, first and foremost, are normal. It's not normal to have them in that frequency, but it's normal to have them. It's the way you engage with those thoughts that makes them so frequent and weekly, and we're gonna learn how to engage with them differently, and in order to break the cycle. And then we went into this part of challenging the interpretations, those distorted beliefs. And that's the C in CBT, this cognitive part. So I talked to him about how OCD is a bully. And then I talked to him about cognitive fusions. This is something that happens very often in OCD. It's where we think, for example, a thought is fused with an action. We cannot make this distinction between a thought and an action. For example, if I think I have the thought that I might stab my girlfriend, that means I'm closer to the action. But we forget that in the middle, we have intentions, right? And he did not have any intention of stabbing his girlfriend. And the second fusion that we see is between the thought and the personality. So for Steve, he felt like if I have those thoughts and I have them so often, then it must say something about my personality, about me being a bad person. But that's not true. Because if you really are a bad person, you will not be distressed by those thoughts. You will just think they're regular thoughts that you're really thinking and meaning. The moment you are scared of your own thoughts, it means that they are not really part of you. They're just white noise of the brain. So this can be a very therapeutic part for a lot of people with OCD. Um, and then we basically worked on those rituals, those compulsions. And what we did was exposure with response prevention, which means you take all kinds of thoughts that distress you in all kinds of situations that you can imagine. For example, standing next to the balcony, or sleeping next to your girlfriend, or cutting a salad next to her. And then you try to actively expose yourself to those thoughts and situations without engaging into the ritual in the ritual. So, for example, one thing that Steve actually really did is cut a lot of vegetables next to his girlfriend in the kitchen. So you do it intentionally and for sometimes for prolonged periods of times, and you want to have two results, or possibly you could have two results. The first one, that doesn't always happen, but a lot of the time, is that if you do it long enough, you notice that the anxiety that is really high or the distress in the beginning eventually goes down, right? Eventually you notice, oh, I've been cutting for a really long time, and nothing happened. So the stress level goes down. It doesn't happen all the time, but it happens often. What you definitely want, and what is the most important part in this exposure with response prevention, is the learning effect. It's this, okay, I've been cutting for a long time and I haven't done anything yet. I haven't done anything yet. What I fear, this outcome of me being violent, hasn't happened. And that's really calming. Um, and for Steve specifically, in addition to the exposure with response prevention, he was also really mentally putting a lot of emphasis on those thoughts. And so this is kind of like mental rituals. When once the thought comes up, you cannot just say, oh, this is an interesting thought, next. You're going into the thought. You're trying to solve the thought. You're trying to solve the problem. You're really debating, will I do it? Will I not do it? Am I a bad person? Am I not a bad person? And this kind of engaging with the thought actually makes the likelihood of the thought coming up more and more higher. So what we also worked on with Steve was kind of letting the thought go, although it's really hard, and letting the thought be there while I focus my attention on what's really important to me. I can still have conversations with those thoughts if I again and again and again switch my focus to the conversation and not the thoughts that are going on in my head. I can still drive my car. I can still go to work. And if I focus on those things that are really important to me in my life, then I will learn also to put less focus on the intrusive thoughts. And they will come up less, or they will be less loud in my head. Okay, so that's all I have to say about the topic today. Let's conclude. So we aren't all a little OCD. It's not a little quirky thing that a lot of people have. It affects about 2% of the population, and it's a clinical disorder that really includes significant distress and impairment. The most known kind of OCD is contamination OCD, but that doesn't mean it's the most common. And also, it's not the only kind of OCD that we know. OCD can sit on about everything that we're afraid of in the world because it's just that kind of belief. Um, OCD is similar to hair pulling in terms of it being compulsive, in terms of the cyclic nature, in terms of some kind of common ground when we look at the brain functioning. And OCD can be treated therapeutically. Sometimes we need to add medication, basically very similar to hair pulling, but for OCD, the most effective kind of treatment is CBT, specifically adjusted for OCD. We call this exposure with response prevention. And it incorporates also psychoeducation and cognitive restructuring. I want to take just another short moment before we jump into the Q&A section to proudly tell you about the fact that in addition to our existing program, TrickStop, that you all well know, and SkinPick, which you might have also heard about, it's very similar to TrickStop just for skin picking. We have created a new program which is called Stop OCD, and it helps you cope with OCD if you have it. It involves all of those techniques and evidence-based strategies that I showed you today and much more. And it's available now. You can learn more about it on all of our social channels, Facebook, Instagram, X, YouTube, and TikTok, or on our website, Stop OCD, where we also have blog articles about the program. So feel free to check that out. And if if you're interested in TrickStop, then I just want to remind you that we have a promo code here for you, webinar 100, that gives you $100 of a discount on your first subscription. Right. So thank you for listening so far. Let's dive in the Q&A part of this presentation. So if you have any question, you can write it down now. I see there's already questions there. So let's check. Isn't the thought that something has to be a certain way a type of intrusive thought? The thought that something has to be a certain way can be intrusive. We call it, but it can also not be intrusive. It can feel very much in line with our values and what's important to us and feel normal and not exaggerated. And then we would call it egosyntonic, in line with us. And then it's not intrusive because it doesn't like jump into our lives and is unwanted. So it really depends on whether it's in line with what's important to you and your values or not. If you feel like you constantly have thoughts about something having to be in a certain way, but you know it's exaggerated and you actually don't always want to deal with having things a certain way, then it's OCD. Usually with OCD, you have some kind of awareness that things don't have to be that way. And then it's an intrusive thought. How do you know if you have just right OCD or Tourette's? For example, I feel the need to flex a certain muscle over and over again. Um, well, that's an interesting question. Just right OCD is usually not about flexing. Like it sounds to me more like Tourette's or some kind of tic, right? If it were Tourette's, it would have been, first of all, it would have to be vocal and motor tics. So it has to be some kind of sound you make and some kind of movements you have to make. And so first of all, it sounds to me more like some kind of tic or possibly Tourette's. And also, I think like for tic disorders, usually what happens before, it's not that you feel like something is wrong necessarily or not in order or not the way it's supposed to be. It's more like a physical feeling. You know, this precursory feeling that you have with tics is that you feel like some kind of itching, or almost like for people who don't have tic disorder, it's described as the feeling you have before a sneeze, and then it just has to come out, right? And sometimes it has to come out for a long time, and the trigger can be stress or all kinds of things, but it's usually not one specific thing. And so for just right OCD, it's more like one specific thing is not the way it's supposed to be. Like I did something with my right hand 3 times, now I have to do it with my left hand. But it's not because I have an itch in my left hand. It's just because that's the way it should be. Um, so yeah, what you're describing sounds more like Tourette's, and just right is more in your head and less in your body, maybe as a general thought. Um, I don't know a lot about neurotransmitters, but why do they give serotonin reuptake inhibitors instead of dopamine reuptake inhibitors? That's a good question. That's a good question. I'm also, again, not a psychiatrist or a neurologist, so I'm not an expert on neurotransmitters, but being a psychologist, I have learned my fair share about it. And it is such a logical thought because I just talked about how we have a hyper dopaminergic activity in the CSTC circuit with hair pulling and OCD, which means there's too much dopamine. So why not dopamine reuptake inhibitors? But that's exactly the point that this is just one aspect of the whole disorder. Um, and so, for example, for OCD, apparently there's also serotonin involved, maybe in other brain areas. And to be perfectly honest with you, there's just also a lot that we don't know. The way that, for example, antidepressants were discovered is just that by accident, people with depression were taking them. And we know those substances increase level of serotonin in the presynaptic, whatever it's called in English, like just in some area of the brain. Um, and that's how we assumed that there's not enough serotonin in depression. It's not that we measured the serotonin levels, you know. So it's just basically we see what works and then we draw assumptions on it. And we know that SSRIs work for dopamine, but theoretically it would make a lot of sense what you're saying. And also serotonin and dopamine are related. Yeah, so it's much more complex, unfortunately, but your thought makes a lot of sense. Um, how can the medication affect your personality or other side effects? Can, for example, hair pulling medicine make OCD worse? It's also a good question. Um, to my best knowledge, medication usually doesn't affect your personality. It does have other side effects. For example, if you take SSRIs in the dosage that is recommended for OCD, then side effects can include all kinds of things like problems with your digestive system or sleep problems or weight gain, but a lot of things. Um, and sometimes you also have those interactions. For example, if you take Ritalin for ADHD, and you like if you have ADHD and OCD, then ADHD and hair pulling, sorry, then the Ritalin can help you with the ADHD, but in some cases it makes the hair pulling worse. And then it's really like up to you how you want to handle that and what is more of a problem to you or what. I mean, ADHD is hard to treat without medication. Hair pulling you can treat without medication. Um, whether hair pulling medication can make OCD worse, not to my knowledge. Specifically, NAC has very, very few side effects, and don't know that it makes OCD worse. But that is definitely something you want to discuss with the psychiatrist and not with a psychologist. Um, How do you know that you need medication? What if you have already tried CBT without luck? Yeah, so that's something that you also definitely want to discuss with your therapist or psychiatrist. But let me just see how much time we have. Oh, we do have time. Um, but for OCD, it would be in really moderate to severe cases that we recommend medication, or if we have OCPD, like obsessive compulsive personality disorder, and OCD, then that's also sometimes indication to give medication. And if you are talking about trying CBT without luck for hair pulling, then yeah, CBT cannot, like, it's the best treatment we have, but it doesn't work for everyone. Um, that would be marvelous if it would work in 100% of the times. I do want to say that sometimes it doesn't work because maybe you weren't with a specialist for hair pulling, or sometimes it's just, it takes a lot of work and maybe it wasn't the right time in your life. But definitely trying like medication for hair pulling usually doesn't work, or based on science, based on evidence, most likely is not going to work without therapy, right? It's not supposed to be a standalone treatment. So what I would recommend is try CBT or another treatment that has been shown to be effective, like acceptance and commitment therapy, again with medication, or try it again post-op. Because the fact that it didn't work once doesn't mean that maybe in a different time in your life, or with more commitment or more time or more resources, it might not work. Can you share a little bit about the overlap with Tourette's syndrome? I think that would be too much to like go into detail here with that. Maybe tic disorders could be an interesting thing to talk about, like comorbidity or co-occurrence of tic disorders slash Tourette's syndrome. Um, and ear pulling would be interesting because they're all also in the area of compulsive disorders. So I'm gonna definitely try to remember that and maybe do a webinar on that. What type of stress or genetic disposition causes trichotillomania? Trichotillomania meaning hair disorder. Um, so the causes of trichotillomania are manifold. We cannot say there's one certain thing that causes it, and we also have to distinguish between the things, the predisposing factors, and then the actual triggers that might lead to the actual manifestation of the problem. So we assume there's a genetic disposition because we see that if one family member has hair pulling disorder, the likelihood of another one having it is higher. We don't know one specific gene that causes hair pulling disorder, but we see it just that there's some kind of genetic disposition by it being more more prevalent with relatives. And we know that some stressful life events can lead to the outbreak of hair pulling disorder. Although we don't have to have stressful life events for hair pulling disorder to start, it can also start randomly. So, and it can be like all kinds of stressful life events. It can be your parents divorcing when you're a child, can be a traumatic event. It can be troubles when you're leaving the house to study at university. Um, yeah, I hope that answers the question. My 17-year-old daughter has trich. She won't seek help even though she wants to stop. I'm not allowed to bring anything up. She recently tried to stop and even told me she was trying but didn't succeed. It worries me. Any ideas on how to share this information with her? Um, so I actually just did a webinar on teenagers and trichotillomania last month, so you can check that out on our YouTube library. It's difficult. I wouldn't push her because that usually just does damage. Um, if she tried to stop, I would really like encourage or praise her for that, or like show that you love that she's trying to stop. But also, if she's open for a conversation, talk to her about the fact that usually you cannot just stop by yourself. And if she didn't succeed, that's not because something's wrong with her. It's just this is a real problem, and you also wouldn't go ahead and treat, physical problems just on your own. You would go to a doctor. So for this, you would go to a psychologist. Um, so I would take a step back. If she's open to talk about it, you could watch the webinar together, although it's really directed at parents and not teenagers. Or you can, watch the webinar and get some ideas on how to talk about it there. Um, and then if you feel a spot opening, mention therapy, but only if you see that she's really like opening up, because otherwise, if you push too far, you're just creating antagonism. And I know it's scary right now, but she might be open to it in a year or two. Sometimes people just have to mature a little bit. And if you create antagonism now, then you're just kind of reducing the chance of her getting there, on her own eventually. But it's very hard. It's very hard to see your child do this and not intervene. I completely understand. What is the difference between OCD and trichotillomania? I do feel like I explained that in the webinar. There's many, many differences in terms of the medication, the treatment. The compulsions are based on different triggers. One is more based on thoughts, one is more based on all kinds of triggers. The actual compulsive behavior is different. Um, for OCD, it's usually not hair pulling, it's like all kinds of other things. So yeah, like a lot of everything that I didn't mention as a similarity would be a difference. Um, okay. I don't think I'm not gonna get to all of those questions. Thank you so much for asking all of those questions. Um, I think I'm gonna get to two or three more, but then everyone that I can't answer, please feel free to write those to our support@trickstop.com, and then we'll answer them via email. Okay, can you address one, focused pulling versus automatic pulling in light of the brain science you discussed? And then second, what's the best intervention for automatic pulling? Um, so I'm not sure if we know about differences in the CSTC in terms of automatic and focused pulling. I could imagine that there are, but there's really very little research on the CSTC specifically for hair pulling and skin picking disorder, much more for OCD. BFRBs are just less, there's less research on them, which is unfortunate. Um, so I guess there might be, but we don't have any research on that, unfortunately. Not to my knowledge. What's the best intervention for automatic pulling? I would say the best intervention for automatic pulling would be awareness training, which is part of verso training, and mindfulness, specifically the body scan. Um, First of all, to gain more awareness, and then physical barriers, everything that makes you notice the pulling, um, because it changes the feeling, like a glove that you have in your hand or something that you have on your head, and you can switch that up if you get used to some of it. Just everything that makes it feel differently, so you cannot go into this automatic motion because there's something that disrupts the chain. Before I pull my hair, I usually have it imagined in my mind, and the thought most times I ended up pulling. And once I start, I find it difficult to stop. Does that count as OCD? Well, that's a very good question. I would say it depends. It doesn't sound like OCD to me, because imagining in your mind the thought of pulling, um, or having a picture of pulling is not an intrusive thought if you kind of even conjure up the thought, because it gives you some kind of pleasure or idea of like soon I'm going to do it and then I'm going to feel better. um, it would only count as intrusive if you feel like the thought comes up, you don't want to have the thought, you don't want to think about it, right? It's a thought that you don't want to be there. And that if then you feel like you have to pull because the thought makes you so stressed, then it might go in the direction of OCD a little bit. But if you have it more as like, okay, imagining this is going to soon happen, or wow, I want to do it, I imagine it, but like or this internal struggle of like it's coming up, I really want to do it, I want to pull my hair, but at the same time I know I don't want to do it, then that's not OCD. That's you just struggling with the urge and the idea of pulling or not pulling. Okay, I'm gonna answer one more question. What techniques do you recommend for those overwhelming moments when intrusive thoughts come up? Very good question. So that would be an OCD question, and it can be very overwhelming when the thoughts come up. There are several things that I could imagine, depending on, like, I would need more details to tell you which one, but you maybe three ideas. Okay, one would be to use cognitive restructuring strategies. So if the intrusive thought comes up, for example, if it was this intrusive thought of stabbing my girlfriend, then reminding myself, wait, the fact that I have the thought doesn't mean that I'm going to do it because I don't have the intention. But the fact that I have the thought doesn't mean that I'm a bad person, because bad people don't are not afraid of their thoughts. They're in line with their thoughts. So the first one would be kind of challenge the thought and the idea that the thought needs to be right. It's taking the thought less seriously. Then the second one, if you feel really, really emotionally overwhelmed, would be to do a grounding technique. Um, I practiced that grounding technique, I think, in my last webinar also about the teens, but you can find it online. It's very easy. It's called 5, 4, 3, 2, 1. 5 things that you feel, 4 things that you see, 3 things that you, no, 5 things that you see, 4 things that you feel, 3 things that you hear, 2 that you smell, and 1 that you taste. You can look that up. It's a grounding technique, and it helps you just like calm this emotional storm for a second. And then the third one would be to treat the intrusive thought like a fly, right? It's there, it's overwhelming, it's really uncomfortable, but I can now pay all my attention to the fly and try to make it go away, but it's going to come up anyways. It could come up, get back anyways. So I might as well just leave this thought there, and try to focus on the things that are important to me. What did I think about and was doing before the thought come up, and try to get back to that. Um, that might be difficult if the thought is really overwhelming. So sometimes you want to do a grounding technique first. Those would be my 3 ideas. Okay. I'm so sorry for not being able to answer the other questions, but we're really out of time, actually over time. Please feel free to send them to support@trickstop.com and we will answer them for you. Thank you so much for all of you who joined today. It was a pleasure, and I hope wherever you are, what time it is for you right now, what time zone, that you have a nice rest of your day or evening or night. And I hope to see you again in upcoming webinars.